I think it's 3:30, 3:31 in fact. So first of all, I would like to thank all of you for attending this Zoom session. And today we are very, very fortunate to have the main author of the Malaysian guidelines for this. He's taken time off from his very, very busy schedule to be with us and sort of discuss the Malaysian perspective on the treatment guidelines and enlighten us how things have probably changed from what we learned in March to what we're learning now. Dr. Suresh is a senior ID consultant in Hospital Sungai Buloh and also the head of the Department of Medicine there. And he was also a key influencer in the ID fraternity in Malaysia and a mentor to many of us. So without further ado, I'd like to invite Dr. Suresh.
Thanks, Giri. I think can you see my slides?
Yep. Yes.
And can you hear me?
Yes, we can hear you.
Okay. I think what I'll do is I'll quickly go through what I know about COVID now. I think you guys are the experts in COVID compared to me. I came to Tawau to learn COVID. Okay, so first go through SARS, some basics about SARS just to keep ourselves up to date. And so now, initially when we started our COVID work, we thought it's purely a respiratory illness. Now we know otherwise, that it is beyond respiratory illness now. In addition to cough, shortness of breath, it can also cause fatigue and body aches. It can also cause loss of taste and smell. And I think in this surge, we found this quite useful because patients were able to tell us, doctor, from that day onwards, I lost my smell, or that day onwards, I lost my taste. The difference between this and the URTI symptom normally is the loss of taste and loss of smell is sudden onset and is absolute. They cannot taste anything or they cannot smell anything. They also can GI symptoms. So we do see patients with diarrhea. And so it has got a whole varied symptomatology, as we have learned now for COVID, right? It's not just respiratory. With regards to incubation periods, even though we say 14 days, the mean incubation period is 5.2 days. By 95% of them would have got the disease by about 7 days, based on this Chinese study. Another study outside Hubei province, again similar. By about 6 days, 95% of them will have got disease. Even though we keep as 14 days, now we think majority would have got their symptoms by end of 1 week. And so you will see that, our incubation period will slowly shorten as days go by, as we know more. Mode of transmission, we think it is primarily by droplet transmission, meaning droplet transmission. That means if you wear a mask and I also wear a mask, the transmission can be stopped. In some occasions, it will be airborne. That will happen if it's an enclosed space. So if in our pantries and in our changing rooms and in our bilik mayang, I think it can be airborne if people don't, if too many people are staying in those spaces, it can be airborne. And so what I mean by airborne means it can stay in the air for a while, and the next person comes in after a while can also get infected. And so in enclosed spaces, it can be airborne. If you have a prolonged exposure to respiratory particles, often when I'm shouting or singing or exercising, again, it can be airborne. And so especially in these situations, you either stay in a place where it's well ventilated, so best done outdoors, or you have to wear a mask. Otherwise, it can be airborne. And again, the role of ventilation is important. And so you should avoid staying in places where there is very poor ventilation. And so all the more reason we should do most of our business in the outdoors. Regarding direct contact and formites, there is still not direct evidence yet, even though people talk about the virus lasting for hours in plastic and steel and all that stuff. There is no direct evidence that direct contact and formites can transmit and contact in sometimes some contact investigations have pointed a possibility that maybe elevators and restrooms could be the source, but nobody has efficiently isolated live virus from these places. So it is, if at all, if it is, it's a very inefficient mode of transmission, direct contact and fomites. Vertical transmission rarely occurs. There are few case reports of IgM positivity and nasopharyngeal swab positivity in infants, very rare instance. There are no confirmed infants getting COVID from breast. I just want to talk a bit about infective COVID-19 because we are picking up so much COVID-19, but not all COVID-19 are infective. This graph sort of explains this in a bit better way, right? And so the patient's viral load goes up, and then after a while it comes down. Okay, but the way we how do we know the viral load goes up? We use a PCR test. We use a PCR test to find out. But actually, the patient is only infectious for a short time. Rest of the time, the PCR is positive. He is not infectious. Only this part of the PCR is infectious. This part of the PCR is not infectious. So we actually don't have a test that can tell us when is the patient infectious. So we have to understand this part, that we still don't have a test to diagnose infectious COVID. The PCR that we are picking up picks up both infectious COVID and post-infectious COVID, and so it picks up both, and that puts us a bit of a spot. And so the same thing I'm explaining it in a different method is a meta-analysis, looked at all cases of infectivity, and this is what they have summarized. What they have summarized is that the peak viral load in infectivity happens before you are symptomatic or on the day you get symptoms. Contact investigations have shown that most people get infected by somebody who is within day 5 of illness. So if I have got COVID and I've reached day 6 of illness, we couldn't find, if somebody comes in contact with me only on day 6 of illness onwards, there is very low likelihood they're going to get infected. But if the same person comes in contact with me in the first 5 days of my illness, more likely they're going to get infected. So beyond day 6, people think the case control studies have shown that people are not infected. In lab data, beyond day 10, in people with mild disease, mild to moderate disease, beyond day 10, they couldn't find culturable virus. So one way of differentiating whether you have infectious COVID or non-infectious COVID is to do viral culture. If your viral culture is positive, that means you have infectious COVID. Your viral culture is negative, that means you've got non-infectious COVID. And so beyond day 10, people have not cultured the virus in mild to moderate disease. The longest duration people have cultured a virus is at day 20. This is for patients who got severe disease or critical illness or immunocompromised host. In these group of people, the highest they have collected is day 20. So beyond 20, people have not cultured the virus. But of course, the virus can be present for beyond 90 days. This is the one that I mentioned about non-infectious COVID. So what about asymptomatic phase? The one that I mentioned to you is all about symptomatic patients. What about asymptomatic patients? So when somebody is asymptomatic, there could be two possibilities. They either persistently, they're never symptomatic, or they are pre-symptomatic. So they are going to get symptoms a few days later. Okay. So in the persistently asymptomatic, transmission can occur, but we think the transmission is less likely than in the pre-symptomatic phase. So in the persistently asymptomatic, we think transmission will be less, but we don't know when they are most infectious. And so when we identify patients who are asymptomatic and we isolate them, we have no idea when they are most infectious. And we really don't know how to manage this persistently asymptomatic group of people. But if you are pre-symptomatic, 40 to 70% of transmission occurs during pre-symptomatic period. And so before your symptom starts, there is about half. So let's say if I am going to get COVID and I become symptomatic, 50% of my the people I transmit when I don't have symptoms yet. That's the reason why I always wear a mask. The reason I wear a mask is because I know that I can transmit to many people before I get my symptoms. And so pre-symptomatic period, half of the people I'm going to transmit the disease, I transmit before I even knew I got COVID. Okay, and so based on all this, we have sort of loosened our discharge criteria. So in symptomatic group of people, we now discharge them after 10 days, provided the symptoms have improved for at least 24 hours. In symptoms have improved for 24 hours, we discharge them for 10 days. The asymptomatic group, we discharge them after 10 days or from the date of the test. Here, in the symptomatic group, we go by symptoms. In the asymptomatic group, we go by the test. Okay, so that's regarding some basics about the COVID and the infectivity. So let's look at clinical categories. So this is how we categorize COVID, right? We all know about it. Category 1, Category 2, Category 3, Category 4, Category 5. And this is sort of a category that we initially came up with even before WHO and came up with a classification. We thought this will be easy for us to manage cases because this was very, very easy to identify based on chest x-rays as well as based on oxygen requirement. So we can classify patients, quite an easy way to manage in day-to-day practice. And then we classified category 1 to 3 as mild, category 4 and 5 as severe. So anybody requiring oxygen is called severe. Anybody not requiring oxygen is called mild. Supplemental oxygen is called mild, right? Okay. So this is the data. I think one of the things that I have to congratulate all the ID units for coming together despite the pandemic and working with CRC of the relevant hospitals and collect data that we sort of use now, right? And so we collected about 5,008 in the first 2 waves. We collected data from 5,800 patients. And we know in the first 2 waves, not the current wave that Sabah is going through, we found that 50% of them were stage 1 asymptomatic, 32% were stage 2, and 14% were stage 3. And we also knew about 8% of them get severe disease. 8% of them get severe disease. So 92% of them get mild disease and 8% get severe disease. And we also knew that about in the 8%, this 8%, 4.5% of them came in very ill, while 3.5% came in well and then turned ill later in the hospital. So 3.5% turned ill, while 4.5% were ill right from the day 1. And that's what we have before this particular surge, right? But based on this is my experience, because as you know, Klang Valley was heavily affected in the first and second wave. This was my experience, and with this experience, when I went to Tawau, I got a shock because the presentation was totally different. So on October 9th, 2020, I compared the patients in Tawau and Sungai Buloh. How are the patients in Tawau and Sungai Buloh to see what they look like? So category 1, we had 60% of our patients were category 1 in Sungai Buloh, while in Tawau it was 27% were category 1. 26% were in category 2 in Sungai Buloh, similar number category 2 in both. 8.9% were category 3, that means they had pneumonia in Sungai Buloh, while 29% were category 3 in Tawau. Category 4, those who require oxygen, 3% were requiring oxygen in Sungai Buloh, where 14% require oxygen in Sungai Buloh, in Tawau. 0.56% required ICU care in Sungai Buloh, while 5% required ICU care in Tawau. And so it was a totally different presentation. I think we should collect, we have to collect this data and look at it again with regards to how COVID has changed that. And one of the reasons why we think this happened is because of this. There's a very nice pictorial graph that shows the whole COVID experience. So as you can see here, when you get COVID, 50% of them no symptoms, 50% have symptoms, many of them mild symptoms, they never require uh, 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 um, very few require hospital admission. Only 20% of them symptoms are severe enough to require hospital admission. And so maybe what Tawa was seeing, or probably rest of Sabah was seeing, is this part of the curve, this part of the graph, while I was seeing the whole graph, maybe at least this part of the graph. And so depending on which part of the graph you're seeing, the presentation looks different. The other reason why I presume you are seeing Sabah was seeing a different profile was actually the age of the disease. In the first cohort, our median age was only 30 years, but at least I know in Tawau and Sampurna, the median age was 45 years. And so I don't know yet the median age for Sabah. And so again, the issues regarding the age. Every country you go, depending on the age of the people who get infected, the mortality rate and severity is different. Even Malaysia is the same thing. Our mortality didn't go far away from this particular graph. Our mortality is very similar to this mortality. And so it all depends on who gets infected with COVID in that particular locality. So that's the classification that we use, category 1, 2, 3, 4, and 5. And so now, based on the data that we have collected so far, we think we can also come up with a different kind of classification. This is classification based on risk of deterioration, meaning if somebody comes to us very stable, very well, what is the risk that they will deteriorate? I think this is useful for us to manage clinical management. And so that's why I'm referring back to the data that we collected. All the hospitals in Malaysia contributed to this particular data during the first and the second wave to come up with the data set. And this is what we have. We had 5,600 group of patients who we have the age, and it tells us that if you're 12 to 30 years of age, you come to us, you come stable, and 2,400 came to us stable. Nine of them deteriorated, and so the 0.36% deterioration rate. If the age group is 31 to 50, there's a 3% deterioration rate. If you're 51 to 70, you've got a 9% deterioration rate. And if you're 71 plus, 1/3 of them will deteriorate. And that's the data that we have, very much dependent on age. The next thing that we put up is, and so as you can see here, the place where it sort of cuts off is at 50, right? 50, the rates are quite high. And so we looked at it a bit differently. Again, 5,000 group of patients, whether they had comorbids or no comorbids. Less than 50 without comorbids, there's a 0.96% deterioration rate. And so this particular group of people do very well. Less than 50 without comorbids. Less than 50, but you have some comorbid, then the rate is higher, 5.51%. More than 50, but no comorbids, again 6.167%. So fairly similar deterioration rates. But if you have more than 50 and you have comorbids, your deterioration is very high, 15% deterioration rate. And that sort of puts you, and so you can actually have sort of a risk ladder based on just this group of patients. So the lowest risk will be less than 50 with no comorbids. The next highest risk is less than 50 with stable comorbids, or 50 to 70 with no comorbids. And so these two are similar. And if you have 50 to 70 and you have comorbids, you've got a higher risk. And if you're more than 70 years old with or without comorbids, you've got the highest risk of deterioration. So it sort of tells you on admission. So this tells you if somebody comes to you stable, if you're unstable, you don't need a risk stratification tool. They're unstable. If they come to you stable, your age and comorbids gives you a very good idea what kind of groups are going to deteriorate. Okay. And then, so that's what we have put up here. So age more than 50, and then the comorbids. And the comorbids that are of importance to us is chronic kidney disease, hypertension, cardiovascular disease, obesity, BMI more than 30, pulmonary disease, and diabetes. The others might be significant, but we don't have data for that. But people use biologics in like rheumatology patients who use biologics, transplant patients and patients on immunosuppression. uncontrolled HIV, likely high risk, but we don't have data for this. The biggest data is for this group of patients. And when do they deteriorate? They deteriorate between day 5 to day 10 of illness. How to predict their deterioration? In addition to risk factors, we also talk about warning signs. And I will tell you what these warning signs are, right? And the reason why we're using warning signs is we are trying to follow the dengue model, right? As I mentioned to you earlier, we have 3.5% of the patients, 3.5% of the patients coming to us very stable, but then deteriorate. They go on to category 4, category 5. And we think those who deteriorate tend to have warning signs. So if you keep on monitoring for warning signs, we can pick up the group of people who are going to deteriorate. And that's why warning signs are extremely important. And what are these warning signs? We've got clinical warning signs, laboratory warning signs, and radiological warning signs. The clinical warning signs are persistent or new onset fever. Anybody has got persistent or new onset fever. Fever continues day 3, day 4, day 5, day 6, fever continues. Persistent symptoms, day 4, day 5, you're supposed to get better, but you now still have cough. You still are not very well. You're still very lethargic. Then you are considered clinical warning signs. Somebody has got reduced level of consciousness, but it's not because of hypoglycemia, uremia, or something like that. Again, it's a warning sign. And then somebody you develops respiratory compromise, be it exertional dyspnea, exertional desaturation. What I mean by exertional desaturation means we ask the patient to sit and stand for 1 minute, and then we check the pulse oximeter. If the SpO2 drops more than 3%, then we say there's exertional desaturation. People are tachypnic. SpO2 is less than 95% in room air. These are all considered warning signs. Laboratory warning signs can be any one of these three. A rising CRP value or CRP value more than 50 milligrams per liter. A single CRP value more than 50. Same like the age, more than 50. Dropping absolute lymphocyte count or single value less than 1 or 1000, whichever value you use. And then neutrophil lymphocyte ratio more than 3.13. Again, a laboratory warning sign. And of course, X-ray looks horrible or X-rays are worsening. Again, it's a warning sign. And just to give you an example of using NLR, we have data to back up these statements. So if you can see here, less than 50 and NLR is less than 3.13, the chance of deterioration is 1%. If less than 50 and the NLR is more than 3.13, the chance of deterioration is 2.69%. If it is more than 50 and less than 3.13, the chance of deterioration is 6.61. If you have more than 50 and NLR is more than 3.13, the chance is almost 24%. Again, showing that these warning signs along with age, gives us an idea who is going to deteriorate, who is not going to deteriorate. And these are the ones that you look for every day. And so this is the language. There's a COVID language that you should talk about. The same way we use dengue language. We talked about compensated shock, decompensated shock, warning signs. You have to talk the same language when you manage COVID. You should talk about warning signs. You should talk about critical phase, and you should talk about high risk groups. Okay, so that's regarding risk stratification of COVID. And the risk stratification is very useful to decide whether patient stays in PKRC or comes to the hospital and how to manage them in PKRC. Moving on to medical management of COVID. This is a natural history of COVID, right? The patients comes up with, initially there is a viral replication that happens in the early infection. So during the viral replication, they have asymptomatic or they have mild to moderate symptoms. I realized, especially when in Sabah, many patients comes to us with very severe illness. They tell us that we ask them the duration of illness. They tell you, I was just sick yesterday, or 2 days. The onset of illness just 2 days. It is because they completely miss this phase. They are oblivious of this phase because of maybe they are truly asymptomatic, or they ignore these mild to moderate symptoms. And so they present straight away in the pulmonary phase. In the pulmonary phase, there is viral replication still going on, but there is also immune response coming in. These are the patients who have pneumonia. They start having dyspnea. If you do a CT scan, you can see ground glass opacities. When you do a chest X-ray, there are patchy ground glass opacities, mainly in the peripheral region. So these are the ones that are present. And in late stages, there is no more viral response. Predominantly, the response is the host inflammatory response, where you see pneumonia, sepsis-like presentation, respiratory failure, ARDS, and cytokine storm. So these patients present like a severe bacterial pneumonia. You cannot differentiate them from a severe bacterial pneumonia or septicemia. They present very similarly. They don't have septicemia, but they look very similar. And so there is also, that's the most common group of patients that you see. Severe presentation is this. There is predominant host inflammatory response. But we also have another profile. This is a profile that we see where what happens, there is not much inflammatory response, but the comorbid medical condition becomes florid. So there are patients coming to us with APO. There are patients coming to us who are end-stage renal failure patients who are coming to us fluid overload. And so that's another profile of severe disease. So the one profile of severe disease is this patients coming to us with host inflammatory response, high CRPs, fevers, and also another group of patients who come to us with their cardiac failure getting worse, with their end-stage renal failure patients coming to us fluid overload. We have to learn to pick up these group of patients too. And so, given that phase, a viral phase, early pulmonary phase, inflammatory phase, the treatment obviously has to be different. So what you give for a viral phase cannot be the same for early pulmonary phase. What you give for early pulmonary phase may not be may not be adequate for the inflammatory phase. And so we think, in the early pulmonary phase, in the early viral phase, you might have to give antivirals. In the pulmonary phase, you might have to give antiviral, steroids, and anticoagulants. And in hyperinflammatory phase, the role of antivirals becomes smaller, and we should think of giving anti-inflammatory therapy and anticoagulants. And so somebody mentioned that, skill in medicine consists in eminent degree in timing the remedies. And that's the reason why I feel many of the clinical studies in COVID don't come out very significant, because it is all about timing. A different treatment at a different time phase won't work. I think it's similar to dengue, you see. You can't run a colloid study throughout the dengue phase and say colloid will never come back significant. But in a patient with decompensated shock, if you run colloid is useful. And so many of the studies that come don't look at the timing, the remedies, and the reason why we are unable to use many of these clinical studies that coming out, clinical research that is coming out for treatment, because they don't time the remedies. So based on this, unfortunately, our treatment guidelines, a lot of it is based on expert opinion rather than evidence-based. And so our current treatment guideline says for category 1, category 2, we don't treat these patients, but we ask to look for warning signs. But we do recommend favipiravir as an antiviral to treat people who have got more than 50 years of old with comorbids. So even if they have a pneumonia, we want to treat them. More than 50 years old comorbid, because I showed you earlier, this group, the chance of deterioration is very high, and we want to treat them during the viral phase, at least during the pulmonary phase. We also want to treat end-stage renal failure patients early because they deteriorate very badly. Unfortunately, we don't have a drug that is useful in these situations, and so that's why we mentioned here, you need to consult ID physician on the choice of treatment. And of course, anybody who's got a warning sign, we should consider them for antiviral treatment, provided the treatment is early. In late inflammatory, the hyperinflammatory phase, of course, the antivirals may not be very useful. And so the dose of treatment that we are recommending is 1,800 milligrams BD for 1 day, was followed by 800 milligrams BD for 5 days. We are capping the treatment for 5 days because we think there is a study in remdesivir showed comparing 5 days and 10 days, and 5 days was similar. we are saying that in the hyperinflammatory phase, antivirals will not be very useful. Remember, favipiravir is teratogenic, and so it is contraindicated in childbearing women and also in men whose partner is childbearing. And so, but if you have to use it, we have to remind patients that for the next 7 days after stopping favipiravir, they have to use contraception. So favipiravir lasts in the system only for 7 days, and so after stopping favipiravir, for the next 7 days, they should use contraception. It is contraindicated in GFR less than 30 ml per minute, but there are case studies showing that in end-stage renal failure patient, regular dialysis, you could use the same dose. So, if you have an end-stage renal failure patient, you should consult an ID physician who will weigh the pros and cons and decide whether he wants to treat with favipiravir. The common side effects are hyperuricemia, diarrhea, elevated transaminases, and neutropenia. So we should watch out for the hyperuricemia. We should watch out for it. The drug interaction that you remember, if you're using paracetamol, only maximum 3 grams is allowed. For theophylline, you should theophylline increases favipiravir levels, and watch out if you're using pyrazinamide, because both pyrazinamide and favipiravir can cause hyperuricemia. The next treatment that we have mentioned is about anticoagulants. And so our proposal is anybody who requires supplemental oxygen, category 4, use the prophylaxis dose of low molecular weight heparin. So I'll give you enoxaparin as an example. Use 30 to 40 milligrams daily. If in ICU patients, so we don't use based on D-dimers. In ICU patients, we use high prophylactic dose. For example, if you use enoxaparin, Clexane, we are suggesting 0.5 milligrams per kilogram 12 hourly. We have a short threshold to use treatment doses of enoxaparin. That is 1 milligram per kilogram 12 hourly. In anybody who has got confirmed venous thromboembolism, PEs, or if you find a lot of clotting in the vascular devices, we recommend using full dose anticoagulation. So that's where we place our antivirals. This is where we place our anticoagulants. In addition, we also have some tricks up our sleeve to manage our category 4 patients. We tend to our category 4 patients, we ask them to have complete rest in bed. We teach them self-proning. We even give them urinals so that they can rest in bed. And we also effectively manage the diarrheas by using loperamide, so that the need to go to oxygen is toilet. In fact, we have got some portable oxygen, and we even give them portable oxygen when they need to go to the toilet, because we think if they exert too much, there is a lot more, there is an increase negative intrathoracic pressure. The negative increase intranegative thoracic pressure worsens the ground glass opacities in the lung. And so this is something that we learned from the Chinese, and we do force our category 4 patients to be completely rest in bed. And also reminder to check all patients that you start on COVID. Please go to the website, this website, to look for drug interactions, because we might miss some of these drug interactions. Okay. The most controversial thing that I just want to talk about will be anti-inflammatory therapy. And this is something that we are still grappling on. We're really not sure how to manage these cases, right? Okay. So this is a recovery study that told us that, probably the only study that showed mortality benefits significantly is they used 6 milligrams daily of DEXA for 10 days. And they were able to show that, in mechanically ventilated patient, they could bring down mortality by about 35%. And in people who have got supplemental oxygen, the category 4 patients, they're able to bring down the mortality by 20%. But in those people who did not require supplemental oxygen, category 1, 2, 3, there was no benefit. In fact, there is some indication that this could be harmful, right? And so in mechanically ventilated patient, mortality reduced from 40 to 28%. On supplemental oxygen, mortality reduced to 25-20%. But remember, there is still high mortality. This kind of mortality we cannot manage. And so DEXA 6 milligram daily alone is not going to cut it. because Dexa 6 milligram daily brought down the mortality, but there is still significant residual mortality that is happening, right? So I'll give you an example of this particular case that I saw from in Tawau. There's a 62-year-old male, diabetes, so 62-year-old male with diabetes, and so high mortality combination. Comes to hospital Sampurna on the 2nd of October. The patient started having symptoms since 26th of September. So cough, fever 1 week, SOB already 5 days. On arrival, his SpO2 is 70% on room air. 70% on room air. And he in high flow mass, they reach 98%. They intubate him in Sampurna Hospital, right? And so, as you can see, his ALC is 1.3, his white cell count is 7.5. And so he's intubated, sent to Tawau. Tawau, they start him on favipiravir, they give him Clexane, they give him dexamethasone, 6 milligrams. They decide use 2 divided doses, and so they have followed the guidelines from most international bodies, right? So they given antiviral. Yeah, we don't have remdesivir, but they gave favipiravir, they gave Clexane, they also gave dexamethasone in the dose that's provided. And so this patient does for a while, extubated on the 6th, changed to nasal prong, but then gets upgraded to face mask, and then requires high flow nasal cannula. By then he's already 5 days on dexamethasone, favipiravir, and Clexane, and they already upgraded the antibiotic to meropenem. But now he's back. So this is what you see. So he comes with a ferritin of 22,800. CRP as 109. And the next day it goes up to CRP goes up to 211, and ferritin 4,000. As you know, he gets started on dexamethasone. His CRP comes down 152, 658. Gets extubated. Here on the 6th he gets extubated, but then CRP starts going up again, and then he gets high flow nasal cannula again. So these are the patients that we don't know what to do. Our guidelines that we have, the studies that has been done so far, is not preparing us for cases like this. And so based on very much, expert opinion and lessons that we learned from Sabah mainly, the ID physicians have come up with these recommendations. Having to say that we don't have trial evidence to back up these recommendations. So we are saying start everybody on 6 milligrams of either IV oral or IV for 5 to 10 days. But in patients who present severe disease, what do we mean by severe disease is those requiring high flow mask or ventilation, and they have high inflammatory markers. So these are the ones that we think are in hyperinflammatory phase. The hyperinflammatory phase, we are recommending don't use just 6 milligrams. It's not good enough. You might have to give 8 to 12 milligrams of dexamethasone, or if you want something equivalent to 1 to 2 milligrams per kilogram daily of methylprednisolone, you start with such high dose and then taper down. So it can be either 8 to 12 milligrams of dexamethasone, or it can be methylprednisolone, 100 to 150 milligrams of methylprednisolone. Either of those two, if patients comes to you directly with severe disease. So just to remind you, 1 milligram of methylpred is 0.2 milligrams, so 5 times. And so if it is 80 milligrams of Dexa, that is equivalent to about 8 times 5, 40 milligrams of methylprednisolone. So in the case that I showed you from Sampurna earlier, you start them on 6 milligrams daily, but patients continues to worsen with inflammatory markers increasing. Suggest double the dose. Instead of 6 milligrams, you could go up to 12 milligrams of dexamethasone, and once patient improves, you can taper it. And I mentioned earlier regarding the methylprednisolone, and so 100 to 150 milligrams of methylprednisolone. The duration tapering of dosage in patients who got mild disease, even 5 days of DEXA is enough. So steroids can be stopped 48 to 70 hours after patient has responded clinically with reducing CRPs. But in severe cases, if you stop within 5 days or so, we have seen rebounds. And so in severe cases, you have to gradually taper the steroids over 2 to 3 weeks, guided by the degree of hypoxia and CRP. And I mentioned earlier, these are all experts' opinion rather than based on evidence, and we need to work it. We need to now do clinical trials on these protocols and see whether we're on the right track or not. So that's regarding patients deteriorating. And the inflammatory markers are going up. This is a study that looked at, again, corticosteroids, and they looked at the patients who received corticosteroids, and they found something interesting. They found patients with CRP levels more than 20, there was a very benefit, about 80% reduction in mortality or mechanical ventilation. But if the CRP levels are less than 10, there's a steroid actually made the persons worse. There's an increased risk of mortality or mechanical ventilation, 2 times higher risk of doing worse outcome. And so looks like while dexamethasone or any steroid for that matter works in the hyperinflammatory phase, and patients who are not in the hyperinflammatory phase or inflammatory phase, as evidenced with CRP less than 10, steroids may not be useful. And so maybe there is another profile of patients. So I mentioned 2 profile of patients earlier. One profile of patients, the one that go into pulmonary phase with increased inflammatory markers, and a hyperinflammatory phase with the inflammatory markers reaching the levels of sepsis. There's another profile of patients where the underlying disease worsens, the cardiac failure worsens, the end-stage renal failure patients, the fluid overload worsens, but COVID itself is not very severe. So that's another profile. Probably there is a third profile of patients where the patients who cannot control their viruses, and their viruses really causes a viral pneumonia. And so these patients worsen without increasing in CRP, without increasing in ferritin. And these patients, we still don't know how to treat, because these patients will already be on favipiravir right from day one. And we know our antivirals are not really the game changer. We don't have a powerful antiviral yet. And these are the places where we are wondering whether convalescent plasma might be useful in these situations. And again, this is something that we need to study more. And so with that, I'll thank you. And I just want to let you know, just to remind you that whatever you're seeing now, I know the case in Sabah coming down, just to remind that this is not even the beginning of the end. Rather, this is the end of the beginning. We now need to realize we have a long road ahead of us with regards to COVID. Given that there's a long road ahead of us, I just have a few messages for you, right? Message number 1. Learning that that COVID has got such diverse presentation, we have changed our case definition. Our case definition is fairly liberal now. If fever, any of these symptoms, if you have any two, you fulfill the clinical criteria for COVID testing. Or more severe disease like cough, shortness of breath, or if somebody has loss of smell or loss of taste, again, you can test them for COVID. Anybody present to our hospitals with severe respiratory illness, again, you can test for COVID, provided they have attended an event or with a known COVID cluster, or from red zones. So one of the way of deciding what is this is any place where there's MCO or enhanced movement control order. Again, these people are eligible for testing, and so please test more, be it in primary care, be it in your hospitals. Test more any patient that fulfills case definition for COVID, because without testing more, we won't pick up more. The second thing I want to I have to explain is we cannot be using so much hospital space for COVID, because we need the hospital to manage other diseases too, and so we need to maximize our usage of PKRC in our hospital. We have to learn to use our PKRC better. And so based on the data currently, age less than 50, no comorbids, ADL independent, and who don't have ongoing need for hemodialysis, we might have to use PKRC. We need to put up good protocols in PKRC to pick up warning signs so that we can identify these group of people, the 3.5% of the patients who will deteriorate, and then transfer them back to hospitals. But we need to use PKRC better and maximize them so that most patients are in PKRC and not in hospitals. The third one I need to mention is we need to decrease healthcare worker infections. In Sabah now, based on the current data, 38% of the healthcare workers are infected from the community. 33% of the healthcare workers are infected from other healthcare workers, and only 4% are infected from the patients. And so it really tells you what you need to do to decrease healthcare worker infections. You need to practice what you preach outside the hospital. And number two, we need to really remember it is just not patients that we are going to get COVID from. We are going to get from each other. And so these rules apply not only to the public, to us too. So the best way to decrease the risk is to make sure all of us are masked, and also to make sure we avoid confined spaces, and remember, in pantry where we cannot do this in a pantry, we really have to make sure we have social distancing and good ventilation in our pantries. Practice what we preach. And the last message to all of you is this: remember, this is a pandemic, and it is not going to be easy. We are all going to be stretched. So don't be crybabies and just man up and let's just do it. And we are all going to be stretched. We are all going to have sleepless nights. We just have to man it up because this is a pandemic. I can't imagine people telling us that, in the Great Depression or World War II or World War III, they had life easy for them. I'm sure they were stretched, and we are all going to be stretched, and we'll have to be prepared for it. The second message is think out of the box for solutions. This is a pandemic. This is something unheard of. And so we are going to go back to traditional solutions, and we are not going to go very far. So always think out of the box for solutions. And remember, it can also be an opportunity to solve some of our perennial problems. And so use this as an opportunity to solve some of your perennial problems. And the last thing, to succeed, we need to adopt a whole hospital approach. It is not an ID unit approach. It is not a medical department approach. It has to be a whole hospital approach, meaning the emergency departments, the bed management units, everybody should come together and manage this. And also it has to be a whole MOH approach. The reason I'm saying that is because there is so many barriers between public health and hospital that we have. And we should break all those barriers and say it's a whole MOH approach. Your problem is my problem, and my problem is your problem. And in addition to MOH, it has to be a whole government approach. So don't try to manage problems purely within MOH. You need to take the whole you need to be able to galvanize the whole government for your approach. And so stuff like logistics and all the stuff, medical management has to be MOH. Nobody else can do other than us. But logistics, transport, all that can be beyond MOH. Controlling the disease, controlling the spread of the disease has to be a whole government approach. I get disappointed when Ministry of Health colleagues blame Ministry of Health when the disease goes out of control. Disease going out of control cannot be MOH alone. Just the way dengue, when dengue spreads, when mosquito breeding goes out of control, it cannot be MOH that can control dengue spread. Similarly, it cannot be Ministry of Health that is going to control COVID spread. It has to be a whole government approach. And that's all I have for you. Thanks.
Thank you very, very much, Suresh, for the excellent talk as usual, and enlightening and inspiring last words. Hopefully, everybody could sort of take it to heart, and as Dr. Suresh said, man up and get everybody involved in the trenches of things.